which is patient safety report on the road from medication safety report to institutional change. Hi everyone, thank you for being here today. Medication safety affects every single one of us, from pharmacists, technicians, providers, nurses, and most importantly, our patients. Today, we want to shift the conversation away from blame and towards learning, system improvement, and prevention. Throughout this session, we'll be using real patient safety event examples, including one we'll preview early and return to later to show how medication errors happen and, more importantly, how they can be prevented.
Hi, my name is Sarah Fresvik.
Hi, everyone. My name is Paul Nguyen.
My name is Sunny Park. Hi, everyone. I'm Michaela Susi.
Hi, I'm Sandu.
Before we begin, we just want to disclose that we have no conflicts of interest related to this presentation, and none of the faculty for this activity have relevant financial relationships with ineligible companies to disclose. By the end of the session, you should be able to do 5 key things. First, define medication safety officers and their role in reducing and preventing medication errors and improving patient outcomes. Second, describe non-punitive medication error reporting and explain how it drives open reporting, learning, and safer patient care. Third, identify instances that warrant a med safety report and be able to implement a report. Fourth, we have understand how medication safety events are reviewed to identify risk within the medication use process. And lastly, we have implement strategies to mitigate problems identified from medication safety events to support improvements in medication use process and patient care. We have a couple pre-assessment questions we'd like you to keep in mind as we go throughout our presentation. The first is, which of these is not a core responsibility of a medication safety officer? Our second question is, which of the following is an example of a non-punitive response to medication error? And the third question is a case, which is PH is a 45-year-old male who underwent an elective bariatric surgery. All perioperative antibiotics and standard postoperative care were appropriately administered. Several days after surgery, PH developed fevers and chills. A subsequent investigation revealed that the autoclave machine used to sterilize surgical instruments was not being properly maintained. Where did the event originate in this case? And our last question is, which of the following strategies is the weakest? So just keep in mind of these questions as we go through our presentation, and I will pass it over to Fan to do a case review.
All right, thanks, Emma. So to ground these concepts, we're going to start with a brief PSI, or what we call our institution patient safety intelligence case. This is an example we will return to later and walk through it in more detail. Before we move further into medication safety concepts, we want to briefly introduce this real case from 2019 involving a 67-year-old patient on chronic apixaban that was held for surgery. What's important to note is that the decision to hold apixaban for surgery was appropriate. What went wrong happened after that decision. So at discharge, medication reconciliation was not completed and Epic defaulted medication to continue. As a result, the patient restarted apixaban at home and returned the very next day with an intracranial bleed. We are not going to analyze this case just yet. For now, we want you keep this case in the back of your mind as we walk through key medication safety principles. So as we move forward, we'll build the tools needed to understand how errors like this happen, not because of one mistake, but because of system design. Later, we'll return to this case, apply those principles step by step. So with that in mind, let's start with our first objective. Take it away, Michaela.
Thank you so much, Fan. So before we begin, we need to have a basic understanding of the term medication safety officers. The Institute for Safe Medication Practices, or the ISMP, defines medication safety officers as individuals who optimize medication safety. They do these through the following 6 roles. First, we have champion, who is a visible campaigner and authoritative resource on medication safety. Next, we have the evidence and knowledge steward, who is a centralized expert on organizational medication safety, related evidence, information, and knowledge. Next, we have the strategist and advocate, who is a voice that is establishing medication safety as a core value for both the individuals and the organization itself. Next, we have the facilitator, who is a team leader who is leveraging scientific strategies to embed safety and sustain improvements at both the local and organizational level. Next, we have the cross-discipline leader, who is a connector who is engaging all in medication safety efforts. And lastly, we have the data optimizer, who is coordinating investigations of medication error reporting data to ensure that they result in overall tangible improvements. The main cause of adverse drug events are that it leads to direct patient harm, unnecessary hospital admissions, a waste of resources, time away from work, and an increase in costs overall. After the initial development of medication safety officers from the Institute for Safe Medication Practices, or the ISMP, many other organizations have also created their own formal medication safety officer positions. Some of these include the American Society of Health System Pharmacists, or ASHP, and we also have NHS, which is the National Health Service. As of October 2017, according to the Medication Safety Officer Society, or the MSOS membership database, they have identified that there are over 189 different titles used in healthcare systems for medication safety officers. Some of these common titles include a medication safety coordinator, a medication safety pharmacist, a medication safety manager, a clinical specialist, and also a director of medication safety. While this is not an extensive list, here are some of the core responsibilities of a medication safety officer. They help to lead strategies and processes related to medication safety. They coordinate any reporting or analysis of any safety events. They help educate the staff on any safe medication practices. They create any policies and do any process development and improvements. They assess and analyze harm for any medication error reportings, and they implement any error prevention strategies. Overall, structured medication safety programs help reduce medication errors and improve patient outcomes. This has led to an enhancement of patient safety, an improvement in hospital safety scores, and the creation of safe prescribing, administering, dispensing, and monitoring. Some specific safety strategies included are barcode scanning, which includes the 5 rights: right patient, right drug, right route, right time, and right dose. And this serves as a safety checklist for many healthcare professionals to prevent any errors. Next, we have the electronic health record system, which allows instant and accurate access to patient information. And lastly, we have the risk evaluation and mitigation strategies, or the REMS program, which ensures that benefits outweigh risks by reinforcing safe usage behavior, such as any mandatory patient reporting or special education to prevent any severe side effects. And this overall helps demonstrate their role in public health protection. In conclusion, medication safety officers play a vital role in their position, not only within the pharmacy, but in their interdisciplinary team. They help to create a culture of safety within their organization. They advocate for overall system improvements that need to be met, and they monitor and manage any medication event reporting. Now that we have learned all of this about medication safety officers, I'll now pass it on to Sarah, where she'll discuss different types of medication error and their definitions.
Thank you, Michaela. Before we begin, it's important to note that medical errors in U.S. hospitals account for more preventable deaths annually than car accidents, breast cancer, and AIDS. With that in mind, this slide introduces the idea of systems-based medication error reporting, which is a system where healthcare workers can report medication errors without the fear of punishment, even if these errors are unintentional. The purpose isn't to excuse unsafe behavior, but to encourage those to speak out when things go wrong so we can learn from it. When staff feel safe reporting errors, we gain valuable insight into where our systems are breaking down. This can include communication gaps, workflow issues, or unclear processes. Ultimately, the goal is to build a culture of safety where reporting errors is not only accepted, but it's expected and encouraged across the entire healthcare team. Building on the idea of systems-based reporting, Just Culture provides the framework that makes that possible in practice. Just Culture recognizes that most medication errors are not caused by bad clinicians, but by predictable human error within complex systems. It helps organizations clearly distinguish between human error, which should be counseled and learned from, at-risk behavior, which should be coached, and reckless behavior, which may require disciplinary action. This distinction is critical because it reassures healthcare professionals that reporting will lead to system improvements and not automatic punishment. This process increases willingness to report medication errors and near misses by creating a fair and consistent approach to accountability. It supports safer patient care by balancing accountability with compassion. It creates an environment that supports safer patient care and encourages those to make sure staff feel supported and encouraged to speak up about safety concerns. This reporting is what allows organizations to identify system vulnerabilities and implement meaningful system changes. The next step is understanding what we mean by error and how medication error is different than adverse drug events. Errors can occur at many points in care and may include mistakes in prevention, diagnosis, or treatment. For this presentation, though, we're going to focus specifically on medication-related errors. A medication error is a preventable mistake that can occur during prescribing, dispensing, administering, or monitoring a medication. This may lead to inappropriate medication use and may cause patient harm, but harm does not have to occur for it to be considered a medication error. An adverse drug event, or ADE, is different. An ADE refers to actual harm experienced by a patient that is related to a medication. ADEs may be caused by medication errors, but they can also occur even when medications are used appropriately. Many medication errors are not the result of one individual's action. Instead, they stem from broader system issues like we've previously talked on, such as communication breakdowns and medication mix-ups. Understanding this distinction helps us focus on learning and system improvement rather than blame. Now we're going to break down the different subgroups of an adverse drug event. So to start, we have preventable ADE, which is a medication error that reaches a patient and causes any degree of harm. The next is potential ADE, which is a medication error that does not cause any harm, either because it was intercepted before reaching the patient or just due to chance. The third is abnormal ADE, which is an event where the patient experienced harm from a medication, and while not completely preventable, could have been mitigated. And last but not least, we have non-preventable ADE, or adverse drug reaction. This is where harm was experienced by the patient, even though the medication was used appropriately. Distinguishing between human error and negligence is a critical concept in medication safety and just culture. Human error refers to unintentional mistakes like slips, lapses, or knowledge-based errors, which can occur even when well-trained, competent clinicians are trying to do the right thing. A common example in pharmacy practice is confusing a medication due to similar names or packaging, especially in a busy or interruption-prone environment. In this case, the error would be unintentional and is related to system design. On the other hand, negligence involves a conscious decision to disregard known safety rules or intentionally violate procedures put in place to protect patients. An example would be working while intoxicated or knowingly verifying the wrong dose for a prescription that could be harmful. These actions represent a level of risk-taking that go above and beyond human error and warrant a different accountability response. Understanding this distinction is essential because reporting culture is designed to address human error while still holding those accountable for truly negligent behavior. With that distinction in mind, we're going to walk through the medication use process and see where errors may occur along the way. So this slide shows the medication use process, which introduces all the steps the medication goes through from the time it's prescribed to when we monitor the patient's response to that medication. So to start, we have prescribing, where the provider selects the medication based on the patient's condition. Second is order processing, where the pharmacist reviews the order for appropriateness, safety, dosing, and anything that could be unclear. And this is where medication reconciliation plays a role, as especially in transitions of care from like admission to discharge. After that, we have dispensing, where the medication is prepared, verified, and supplied to the patient. Next, we have administration, where the patient receives the medication, and this step is highly vulnerable to errors and relies heavily on accurate orders and clear communication. And last but not least, we have monitoring, where we assess the patient's response to the medication, either by checking labs, watching for adverse drug events, or making adjustments as needed. As you can see, this process involves multiple steps and handoffs, leaving plenty of room for errors to occur along the way. The next question is what we do after an error is reported. This is where the 7 tests of just cause come into play. In a just culture, we recognize that not all errors are the same, and many are unintentional and related to system design, while a smaller number are related to risky and reckless behavior. Due to this, organizations use the 7 tests of just cause to take a step back and ask a few questions before assigning blame. These questions include Was the rule fair, clear, and related to patient safety? Did the employee know the expectation? Was an investigation conducted before deciding disciplinary action? Was the investigation fair and objective? Was proof of misconduct found during the investigation? Have all employees been dealt with equally? And does the response fit what actually happened? Using this approach, make sure we're not punishing people for system failures. Instead, it supports learning and improvement while still holding people accountable if there is a true disregard for patient safety. When staff know errors will be reported fairly and without automatic punishment, they're much more likely to report what happened, and that is where PSI reporting comes into play. When they feel safe reporting at errors without the fear of punishment, we see more PSI submissions, and that is a good thing. More reporting gives us stronger data, which helps us identify trends, perform meaningful analysis, and ultimately leads to system improvement. I'll now pass it back over to Fan to highlight some examples of how just culture and systems-based reporting can be applied.
Thank you, Sarah. We are now going to return to the same Epic Spans case and apply just culture framework. Up to this point, we have talked about just culture, human error versus negligent, and why non-punitive reporting matters. Now we want to show what those concepts look like in real life. Using real patient safety intelligence cases, we will walk through how medication errors actually occur, not as isolated mistakes by individuals, but through predictable and preventable failure points in the medication use process. The goal is to understand what went wrong in the system and how we can prevent the same error from happening again. So let's start by revisiting that apixaban discharge case that we introduced earlier. This patient was on a chronic apixaban for AFib and was admitted for surgery. Apixaban was appropriately held at discharge. However, medication reconciliation was not completed and the provider was able to leave the medication status blank. So Epic interpreted that blank as continue, and the patient restarted apixaban at home. At this point, I want us to pause and ask an important question. Is this human error or is this negligent? Human error. Yes, human error is correct. When we apply a just culture framework, this case aligned with human error occurring within a flawed system. There was no intentional harm and no reckless behavior. Instead, the system lacked enforcement functions and safeguards, allowing predictable error to occur, and this is exactly why PSI reports matter. If events like this aren't reported, these system vulnerabilities remain invisible and unchanged. So that brings us directly to our next objective, identifying which situation warrants a medication safety report and what information makes a report actionable. So Sunny's going to walk us through that next.
Thank you, Fan. So now that we've reviewed the general background of medication safety, let's build upon the baseline knowledge to focus on the situation that warrants a medication safety report and how to submit one. So at our institution at OHSU, we rely on the PSI report to determine when an incident should be reviewed and how it should be resolved. And as for reporting near misses, it's just as important as reporting any events or incidents that result in harm and should be completed with the same level of detail and care. So promoting just culture, not all errors lead to a non-punitive outcome. While human errors and system-based mistakes are addressed through learning and improving, negligence or reckless behavior or malicious intent may result in a punitive action. So just culture in general supports reporting without the fear of punishment for human error. However, reckless behavior, negligence, malicious intent can lead to a disciplinary action. So ultimately, the PSI report allows OHSU to conduct a thorough review and improve a patient's safety and overall improve patient safety. So now that we understand why reporting is critical, let's review the types of medication safety events that can be identified and reported. So some of these terms were defined, but I'd like to highlight them to ensure clarity. And additionally, understanding these terms will help ensure accurate and consistent reporting. So first, incidents, those are any events that reaches the patient with or without harm. Pretty straightforward. Now, for near misses, that's one event that does not reach a patient. Although the event did not cause any form of harm and did not reach the patient, it can still provide a learning opportunity. As for unsafe conditions, those are any circumstances that increases the likelihood of a patient safety event. And some examples are expiring medication that is stored at a pharmacy shelf or a workflow issue such as a technological malfunction. As for medication errors, those are errors at any step of the medication use process, as we discussed, which would be prescribing, dispensing, administering, or monitoring. And lastly, adverse drug event, or ADE. That's when the harm is experienced due to a medication exposure, ranging from side effects to serious or fatal outcomes. So now that we reviewed the concepts of medication safety events, let's take a look at some examples for the types of adverse drug events. So as for preventable adverse drug events, a patient was given penicillin despite a documentation of an allergy, causing an anaphylactic shock. So this example shows that the medication did reach the patient and cause a form of harm, but it could have been prevented or avoided with the proper checks in place. Second is potential adverse drug events, where a pharmacist catches an incorrect opioid dose before giving it to the patient. No harm occurred because the error was intercepted, but it still highlights the system risk and should be reported. And for the third example, which is amiable adverse drug events, that's when a patient receives vancomycin and develops a mild kidney injury. And close monitoring could have mitigated the harm. So in this example, harm did occur and could have been reduced with close monitoring. By reporting, it can actually help prevent similar outcomes in the future. And lastly, it's the non-preventable adverse drug events or adverse drug reaction, which is ADR, where a patient experiences nausea from chemotherapy despite the incorrect administration of the medication. This reaction was not due to an error, but reporting is still crucial for safety tracking and learning. So reporting each of these adverse drug event types ensures that we capture risk and prevent future harm, and continuously improving patient safety. So now that we've covered some examples of the adverse drug events, let's move on to when to report. So first, report any medication safety events, big or small. Reporting doesn't mean anyone is automatically in trouble. Our focus is to learn from our mistakes and improve the system rather than blaming others for honest errors. The main concept of just culture is to understand why errors occur and use the knowledge to prevent them in the future. Do keep in mind that there are instances such as negligence or intentional harm where accountability is required. And reporting is still important in these cases because it ensures the event is properly evaluated and addressed. And when in doubt about reporting, the safest approach is to report. So all reports are reviewed by our medication safety team. We're able to determine the further evaluation, escalation, and system level changes as needed. So in summary, reporting doesn't just protect patients, it helps our colleagues in departments and organizations learn and improve. By capturing all types of errors such as near misses, unsafe conditions, we can enhance patient safety and provide a better quality of care. So now that we understand what and when to report, let's move on to a walkthrough example to see how this works in practice. So in this case, the provider ordered metoprolol tartrate as intended. The pharmacist reviews the order and sees the order is appropriate and no alerts are triggered, and the medication or the order is verified. Now, the nurse removes the medication from the automatic dispensing cabinet and they scan the medication. And BCMA presents the error as this is not the correct medication. It turns out she pulled metoprolol succinate instead of metoprolol tartrate. And later, it's clarified that metoprolol succinate was loaded into the automatic dispensing cabinet instead of tartrate. So would this be a reportable error? Paul?
Yes.
Thank you. So yes, this is an example of a near miss and a potential adverse drug event. And the error was caught before the patient received the wrong medication. But reporting is still important because it helps identify system weaknesses and prevent future errors. And so what are some forms of preventing this example? Well, there's the computerized provider order entry or CPOE alerts, where 2 staff members are to check the high-risk medications before it's dispensed. Second would be staff education, teaching them about what types of medication errors are common in the pharmacy, or continuing to use the BCMA method that caught this error from reaching the patient. And now, actually, OHSU allows providers to hold the medication and not let it pass through. So as for reporting, we recommend using the current system to report. The new system is underway and should be rolling around April this year. So we recommend keeping a lookout for the new updated system. And next, Paul will be covering the components of the PSI.
Thank you, Sunny. Like Sunny just mentioned, the PSI system is currently being reworked. But in the meanwhile, it is still important that all of us know how to use the current PSI system. So I'm going to take this time to briefly go through each of the individual components of the PSI report. When you first try to submit a PSI report, this is the first thing you'll see. The first thing you'll want to fill out is the category of the incident. Is it directly related to a patient or visitor, or is it related to unsafe conditions or improvements? Depending on what you fill out, you'll be expected to include different types of information. Next, it will ask you to choose the primary person affected. This will be a bit redundant since most of the options are the same, but it will allow you to choose an employee as the primary person affected. It will ask for the name and age of the person, but if the person was also a patient here, then it will ask for the MRN, date of birth, and gender as well. If multiple people were affected, there is a button on the bottom left that will allow you to add additional people. This next section will be used to categorize the incident. While we would like to focus on medication-related safety reports since we are pharmacy students, PSI reports are used for all sorts of incidents. Reports can be relating to anything from medications, to supplies, to complications of surgery, and to basically anything that could go wrong in a hospital. Then, depending on the type, they will give you options to further classify the event based on category and subcategory. As an example, if we had chosen medication-related as our type, known drug interaction would be an example of a category, and then drug-drug interaction or drug-disease interaction would be an example of a subcategory. Now let's move on to the timing of the event. It is important that we differentiate between the time that the event occurred versus the time the event was discovered, both of which should be included in the report. In order to help the medication safety officers with their investigation, it is important that a report is submitted as soon as the incident is discovered and including the time whenever possible. An important thing to note is that for safety reasons, the time should always be inputted in a military format. This keeps everyone on the same page and leaves no room for misunderstanding or guesswork. This next portion of the report goes over additional details that would be useful to know, but are not always applicable. This includes if the event is related to the handover or handoff of care, if the patient's size complicated patient care, and how did the reporter learn about the event. Next, we have the location of the event. And of course, we need to know where the event happened, as well as any and all locations and services that were also affected. This next section will be the bulk of the PSI report. It is 2 free response boxes that allow the reporter to describe in detail what happened that led to the incident. The first box will be the description of the event, while the second box is for any additional thoughts, including contributing factors, lessons learned, and recommendations for the future. It is important to try and avoid pointing fingers and to just stick to the facts as much as possible. If a medication was involved in the incident, specifying which medication will help shorten the investigation time. Additionally, there will be a drop-down menu at the bottom that will allow the reporter to identify any sources of bias that could have contributed to the incident. Next, we're going to talk about harm scores. Harm scores are an assessment of how much harm was done to the patient. Harm scores can differ from site to site, with many ranging from 1 to 5 and some ranging from 1 to 10. But here at OHSU, our harm score ranges from 1 to 9. And I'm going to take this time to briefly go through what each of the scores mean. So first, 1 is an unsafe condition that could lead to harm. 2 is a near miss, so an incident almost occurred, but it was caught and corrected before it reaching the patient. 3 is when the incident reaches the patient, but there was no evidence of any harm. 4 is the first one where the patient is actually harmed, but it is limited to emotional distress or inconvenience. 5 is harm that results in the need for additional treatment. 6 is harm that will only be temporary. 7 is more permanent forms of harm. And then 8 is like 7, but more severe. So for example, 7 could be an injury leading to scarring, while 8 could be an injury leading to the loss of a limb. 9 is unfortunately the end of the road, which means that the harm resulted in patient death. After the appropriate harm was assessed, or the appropriate harm was selected, appropriate harm score was selected, it will then ask when harm was assessed and if any intervention was attempted. Finally, this last part of the PSI report goes over information about all other involved parties besides the primary people affected. This will include anybody that was notified of the incident, the reporter, and any other involved parties that were not previously mentioned. Now we're going to talk about now that we are done going over the individual components of the PSI report, it's important that we also go over the Swiss cheese model. The Swiss cheese model is an idea that in any given system that has safeguards put in place, there are going to be weaknesses or holes. Problems occur when multiple weaknesses in the system line up and allow for an error to reach the patient. This exposes a vulnerability in our system. The Swiss cheese model shows that it is usually not one mistake that leads to an error occurring. It has to have been a series of mistakes that arise from the individual level, as well as in upper management and organizational influences. The easiest way to decrease the risk of a hazard making its way through is by adding more slices of cheese, or in this case, more safeguards that make it harder to make a mistake. An example would be using both Tallman lettering as well as physical separation of similar sounding medications to make sure that they are not picked incorrectly. Next, let's move on to root cause analysis. Root cause analysis is a process to identify the underlying causal factors that led to an error. To perform a root cause analysis, you first need to identify the problem and all contributing factors. This picture is an example of a fishbone diagram. These are made to organize and show all the different factors that could cause an error. The problem sits at the head of the fish, while each of the ribs represent a factor that could lead to the problem. Then, along each one of these ribs, continually ask why until you have traced the reasons back to the underlying systemic problems. As demonstrated with the Swiss cheese model, there are multiple causes for why an error occurred. It is important that we identify all prominent causes that led to the error and trace it back to its root cause. This allows us to address the main sources of the problem and not just the symptoms. Now in this next slide, I will show an example of how to do a root cause analysis, but I will be using a non-healthcare example. However, the same idea still applies. And to keep it simple, I will just go through an example of one branch of the fishbone diagram. Now, in this example, the problem identified is that an electric mixer stopped working. Now we just have to keep asking ourselves why until we identify the systemic problem. I won't go through all of it, but when we look down at the last reason, we can see that the motor was overloaded because the material being mixed was heavier than the design limit. In this scenario, you could just get a new mixer or replace the motor. But if you didn't identify the root cause of the problem and just continue without any changes, then you will just end up with another broken mixer and more money down the drain. It is important that we identify that the real problem was that they are using the mixer incorrectly, leading it to break. Similarly, in healthcare, it is important that we don't just reprimand or replace the workers that made the mistake, but identify why the mistake occurred and see if there are any changes to education, workflow, or management that could prevent mistakes like this from happening in the future. This is also why it is important for people to submit PSI reports even if no one was harmed, since it allows us to identify holes in our system and add safeguards before anyone gets hurt. Now I'm going to hand it back to Fan to tie it back to our patient cases.
Thank you, Paul. So we'll begin by revising the expanded case and walking it through using a root cause analysis lens. This slide shows a sequence of events in this case, and at first glance, it may look like a simple oversight, but when this event was viewed more closely, it became clear that the error wasn't caused by one single mistake. Instead, several root causes emerged. First, medication reconciliation was not required to discharge. That's a system design flaw. Second, Epic was designed to default a blank response to let's continue. That's an automation trap. And third, there was poor handoff communication and unclear responsibility for who owned the final discharge medication review. So this wasn't a single provider error. It was a combination of system failure and human vulnerability, exactly as the Swiss cheese model predicts. And that leads us to the most important question. What do we do about it? So after this event, no individual was punished. Instead, pharmacy partnered with the health system to implement real sustainable change. Medication reconciliation is now required for every discharge medication. Epic now includes a hard stop, meaning the after visit summary cannot print until reconciliation is completed, and a clear workflow accountability was established. So responsibility is no longer ambiguous. So this is just culture in action. We learn from the event, strengthen the system, and reduce the risk of future harm. What's important to recognize is that these system fixes didn't happen by accident. They were intentional strategies designed to mitigate risks identified through medication safety reporting, and that bring us to our next objective, how reporting turns individual events into system-wide improvement.
As Stan mentioned, As Stan mentioned, medication reconciliation is a good example of an intervention that can arise from medication safety reports. This is from the ISMP, and they estimate that 50% of medication errors and 20% of adverse medical events could be eliminated with proper medication reconciliation. There are several different types of interventions that can arise following a med safety report. The first is a process redesign. This looks like more checks in place, separating certain things in the case of look-alike, sound-alike, and changing the workflow in such a way that the previous error would not be able to occur. The second type is education or policy reinforcement. This is more like compass modules, refreshers, recertifications, and it relies heavily on humans to prevent error. The last type is system end controls, such as computers complying with security measures. This looks like epic alerts, barcoding, and relies heavily on systems for correction, which makes it the strongest type of intervention. So you see here, this is a diagram further illustrating the types of interventions that we have. At the bottom, we have rules and policies, educational programs, and suggestions to be more careful. These tend to be the least effective in preventing error. However, they are the easiest to implement. It is much easier to have someone redo a compass module than it is to do the things on the top, as we have as forcing functions, barriers and fail-safes, and automation and computerization. These are the most effective, but they are harder to implement. So we want to implement processes that aren't reliant on humans, as humans will make mistakes. By targeting systems, it will ensure that mistakes will not happen again. However, the time it takes to do that and reset the processes should be taken into account. Our medication safety officers have to weigh effectiveness versus what is reasonable to implement at our institution. These are a couple of examples of interventions that we often use. We typically target error-prone processes, such as Fan mentioned earlier, medication reconciliation is a big one. We also use barcoding, and as Sunny mentioned, we have our computerized provider order entry, which essentially makes sure that every order that we have goes through has two eyes on it, one from the provider and one on the pharmacist before we even get to processing it. Now that we know different types of interventions, how will we know if they are effective? So we can explore that a little more on our next slide. So we evaluate impact after we identify deficiencies with our root cause analysis. When we do that, we would produce an audit. This would evaluate actual performance compared to the written word of what we think the effect will be. And additionally, we will also provide feedback, and this would be from staff members and other people involved with the workflow process. And this would also be combined with education and outreach. A little bit more about our audit cycle. First thing we would do is we plan the audit based on what our planned intervention is. We would define best practice according to guidelines in other institutions, and we would collect and gather our data to compare to the best practice. After we compare to the best practice and we will decide whether or not we keep our intervention, we change it, or we alter it slightly. And we will continue to monitor results as we go through this and as we get more medication safety reports. I will now hand it back to Fan to discuss a couple additional PSI cases.
Thank you, Emma. So to better understand the broader impact of reporting, let's look at another case where a serious medication safety risk was identified and addressed. In this case, an outpatient oncology patient was receiving fluorouracil through a take-home CAD pump intended to infuse continuously over 46 hours. Instead, the pump was incorrectly programmed, and the medication was delivered over a much shorter duration, approximately 1 hour rather than intended 46 hours. Because this occurred in the ambulatory setting, the error was not immediately detected. The patient ultimately required inpatient admission and antidote treatment, as fluorouracil overdose can be fatal. So this case raised serious concerns about outpatient infusion workflow, particularly around pump programming, independent verification, and safety checks before patients leave the clinic. It is also highlights how risks can be amplified when high-risk medication are administered outside the inpatient setting, and why robust safety system matters just as much as in ambulatory care. So when this event was reviewed, the issue wasn't that someone wasn't paying attention. There was no drug library safeguards in the pump, no hard stops, and no standardized programming protections. In other words, the system allowed a dangerous error to occur. So in response, pharmacy implemented several changes. We ensure that uridine triacetate, the antidote for fluorouracil toxicity, is always available. And we work with ambulatory leadership to build pump drug libraries so accidental overdose programming cannot occur. So this case shows how reporting doesn't just document harm, it drives meaningful system improvements. So our next case highlights another important role of consistent reporting, uncovering dangerous patterns before patient harm occur. So for patient on continuous renal replacement therapy, or CRRT, multiple different solution bags were stocked, and many of them looked nearly identical. So over time, repeated PSI reports reveal a pattern. The wrong CRRT products were repeatedly being sent to patient care areas. Again, this wasn't about care of individuals. It was a high-risk system design that relied heavily on visual checking and memory. Once that pattern became visible, pharmacy was able to intervene at the system level. Here's what that intervention looked like. To address this risk, pharmacy implemented barcode scanning for CRRT dispensing and began tracking compliance. This removed reliance on visual identification and memory, and instead added a technology-based safety safeguard. Importantly, these changes didn't happen after a single event. They happened because repeated PSI reports made the risk visible and actionable. So what do all these cases teach us? Medication safety reporting helps us move from isolated events to system-level learning. It allows us to identify patterns, redesign processes, and ultimately protect future patients. Medication error almost never comes from one big mistake. Instead, harm usually happens when multiple small issues stacks up, and a workflow gap here, a communication breakdown there, or a system default that don't fully support safety. So when those weaknesses line up, the holes align, and that's when patients can be harmed. So what these cases show us is that errors are predictable, and when we catch the pattern early, they are also preventable. So, and this is exactly why patient safety reporting matters. PSI report allows us to see these patterns across events, identify system vulnerabilities, and implement changes that prevent the same harm from happening again. So these PSI cases show us why reporting truly matters. They drive safer workflow, they prevent repeated harm, they strengthen medication safety culture and improve technology safeguards, and they demonstrate the leadership role pharmacy play in patient safety. Every PSI report is not about blame. It's how we protect patients and strengthen the system. So with that perspective in mind, we'll move into a few final knowledge questions. So no pressure, just a chance to apply what we have discussed. So these are meant to reinforce learning, not just test anyone. So I'll read the question, give you a few seconds to think about it, and we'll walk you through it together. So question 1, which of the following is not a core responsibility of a medication safety officer? A, coordinate reporting and analysis of safety events, educate staff on safe medication practices. C, assign blame to who made the error. D, identifying and mitigating medication risks. C, correct. C is correct answer, assigning blame to who made the error. So a medication safety officer's role is to identify and mitigate risks, analyze events, and improve system, not to assign blame. So this next question focuses on non-punitive response to medication error. I'll read the question, give you a few seconds to think about it, and we'll walk it through together. Which of the following is an example of a non-punitive response to medication error? A, suspending a pharmacist for selecting the wrong strength of a medication due to lookalike packaging. B, disciplining a pharmacist for not catching an error due to an unclear provider note. C, redesigning sub-labels after a pharmacist accidentally grabbed the wrong medication due to a lookalike labeling. Or D, requiring pharmacists to redo a Compass module after an unintentional error due to an epic glitch. C, the correction is C, redesigning sub-label after a pharmacist accidentally grabbed the wrong medication due to lookalike labeling. So that responded addressed the root cause and reduced the risk of the same error happening again. So without punishing the individual involved. So this next question helped reinforce root cause analysis, which is a key concept in medication and patient safety. So I'll read the question, the scenario. You can think about the event, where it originated, just not just where it was discovered or managed. So PH is a 45-year-old male who underwent an elective bariatric surgery. All perioperative antibiotic and standard post-operative care were appropriately administered. Several days after surgery, PH developed fevers and chill. A subsequent investigation revealed that the autoclave machine used to sterilize surgical instrument was not being properly maintained. So where did this event originated in this case? A, lapse in post-operative monitoring that failed to detect infection early. B, inappropriate selection of a pair of antibiotics in the emergency department. C, a malfunctioning autoclave with no failsafe or backup process in place. D, the decision to perform the surgery, which should have been avoided. The correction is C, a malfunctioning autoclave with no failsafe or backup process in place. Even though the infection was identified days later and treated appropriately, root cause analysis asks us to look at the earliest system breakdown, not the downstream effect. So our final question here, look at the strength of safety strategies. As you think about this one, consider which option relies most on human memories and behavior rather than system design. So question 4 state, which of the following strategy is the weakest? A, requiring medication reconciliation at care transition. B, utilize barcode scanning to ensure right medication. C, tell staff members to not forget to double check to dispense medication. D, requiring patient education on the drug regimen. That's correct. Tell staff to not forget to double check medications. Strategy that relies on reminders or vigilance are the weakest because humans are fallible. Strong safety strategy redesign the system to make the right action the easy action. This is why making safety focus on system design over individual perfections. So thank you for your engagement with those questions today. With that, we'll conclude today's content and move to the references. So these are the key references that inform our presentation as for the medication safety principle discussed today. They're included for transparency for anyone interested in exploring these topics further. Finally, we'd like to acknowledge those who supported this work. We'd like to thank for their guidance and support through this project, Lindsay, Jess, Maureen, Alita, Bloss, Katie, and Kat. Can we get a hand of applause? Yeah. Again, thank you for all your time and engagement today. We appreciate the work you do every day to support medication safety and patient care. We are happy to take any final questions.
Okay, my question to you guys as interns, having worked on this presentation and learned a lot about med safety, what are some of the ways that you're seeing med safety improvements being made in the workplace?
We do have the weekly, I believe, huddle at the inpatient where they discuss the PSI incidents that are occurring and how we can improve the system. And I believe our managers at the pharmacy also receives those information to reevaluate to improve our system as well. So,
Can you also repeat the question?
Yeah.
oh,
Great.
Sunny's getting her steps in today with the stairs too. My other question was about as interns and having learned so much about med safety, how are you seeing improvements being made in the workplace? Like, what are some things that you guys have seen, like as you're staffing, working in central, working in Amcare, decentral, all those pieces? What are some things that you've seen to help improve med safety?
To answer that question, recently there was a big change in hazardous drugs. So there's a lot of medication are being moved to table one. So it's a big collaborative and like more of a interdisciplinary team. So where we identify which drug is for table one, and especially with Omnicell, where before there wasn't a prompt telling you that it was hazardous drug. So now there's a hard stop telling you that it is hazardous drug, so that you got glove up and everything. So that's some big changes, especially with women who are getting pregnant, which is very bad, bad as you know.
Also, to build off of what Van just mentioned with the new hazardous system, as interns here, we do audit all the clinics and units from OHSU. And before, we were expected to ask like certain questions to make sure that they are compliant with all the medication guidelines and rules. And with the new system, we see that we have additional questions that we have to ask to make sure that they are understanding the new system and that they are compliant. So that's like a new thing that we're doing to make sure that everyone understands where like the blue gowns are, which gowns are used for handling chemo and hazardous medications, and just where the spill kit is and all of that. Any other questions? The question was if any of us have filled out a PSI before.
so I have. So during delivery, I noticed that one of the units was storing medication that wasn't supposed to be in the fridge as like a return bin. And so we had to throw away all the medications in that unit. And when I spoke to the pharmacist, they said that this is an ongoing situation, and so we should fill out a PSI report. So I filled out a PSI report for that incident.
Maybe just like one or two of you can answer. What was one like really surprising or really interesting thing you learned in your research on medication safety?
This one is like the Pixelman that we introduced earlier is actually a really recent case. It's actually from 2019, so not that many years ago. So that's something that's really interesting, as we every day is a learning experience and everything is being implemented daily. So it's something pretty cool.
I just didn't know that we had medication safety officers, and that was pretty interesting. I didn't know that was a route that we could do, but yeah.
I just don't think I realized how much medication safety officers do. Like, I didn't realize how many different events actually happen. Like with the cases we went through, I was kind of surprised by that. And yeah, I just didn't realize the amount of work that they do to keep our hospitals safe. Any other questions? Okay, we can move on to our code at the end, so you guys can fill that out. Thank you guys all for coming.
Question. I'm sorry, is the code up on a screen? I had to call in via mobile, so I don't have a visual access.
I can also read it. Yes, it is on the screen. It is F4EV7Z.
So F is in Frank, 4. E is in elephant. V is in Velcro. 7. Z is in no, not zebra, zebra, zebra. Did you catch that?
I think I got half of it. I think I got half of it. One more time, please.
Oh, F is in Frank, 4. E is in elephant. V is in Velcro. 7. And then Z as in zebra.
Thank you.
You're welcome.
All right. Yeah. Thank you, everyone.
They both died.
Guys,